share those with our leaders and get those answered as we go. And so one thing I wanted to share is that the Hip Hope Network, we're really proud to be able to bring together experts on different topics and host these kinds of educational events and engagement sessions on all kind of key topics in hip health. So we do also have a number of recordings of past webinars, and there will continue to be more in the future of this series. And one thing I wanted to share as well is that along the same vein, bringing people together and knowledge sharing, is that this September we're doing something very special, a 2-day uh, hip global pediatric hip symposium in Vancouver, Canada, and that's coming up in September 11th and 12th. And it will include panel discussions on all kind of hip health topics by over 50 global experts, plus 30 top hip health research presentations and much more. And particularly relevant because both Jason and Stacey will be part of the program. And the latest agenda and speaker lineup are on our website, and the registration's been open for some time. So if you haven't checked that out and registered, please do that. And yeah, there are already over 100 global attendees registered. So check it out soon if you haven't already. Okay, so I am joining today from Vancouver, Canada, and would like to begin with a land acknowledgement. The Hip Hope Network operates in part on the current unceded traditional and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And we invite all to reflect on the current traditional and ancestral territories, land, and waters which allow us to work, live, and play. And one other thing before we get going is our disclaimer. So want to make sure folks know that while this is educational, the series or the webinar reflects on the opinions, interpretations, and insights of the respective authors and presenters, do not necessarily represent the views, policies, practices of the Hip Hope Network. Webinar is intended for informational, educational purposes only and is not intended to be specific medical advice. We strongly recommend consulting applicable local practices, guidelines, or regulations to determine the relevance and applicability of the content to your specific circumstances. By participating in the webinar, you acknowledge that the Hip Hope Network and its presenters shall not be liable for any errors or damages arising from the use of the content. You expressly waive any claims against the network and its presenters. Your participation in this webinar signifies your understanding of and agreement to these terms. Okay, so having said all that, I will pass it off to our leaders today of the session, Dr. Jason Howard and Stacey Miller. Welcome and thank you.
Thanks. Good to be here.
Over to you.
Thanks, Joel. I'll pull up my slides and then I can give us. You see that all right?
Not yet.
Not yet. Okay. I've done something wrong.
Here it comes.
How about now? Good.
Yes, we see your PowerPoint view, and maybe there we go. We're in good shape.
You're good. Okay. Thanks. I'm Stacey Miller. I'm a physiotherapist. I work clinically at BC Children's Hospital and coordinate a provincial hip surveillance program here in British Columbia for children with cerebral palsy. I appreciate the invitation to come and share some of the work and learning that we have done over the past 10 years or so of implementing population-based hip surveillance for children with cerebral palsy. So I'm going to spend the next 15 or so minutes just talking a little bit about hip surveillance, describing the problem of hip displacement and what we know about hip surveillance for kids with CP. We'll look at the guidelines that are available for surveillance and then talk about how to implement those guidelines, which I think is the tricky part, and talk about some of the challenges that may come up and hopefully provide some solutions to those barriers as well. So we know that children with cerebral palsy are at risk for hip displacement. You can see here the contrast of a child with typically developing normal hip alignment on the left side of your screen, and that of a child with cerebral palsy, where you can see that the child's right hip, the one that's in the left part of this screen, of this x-ray, is partially displaced, and their left hip is fully dislocated. And if we look at this series of images that are from the same child with cerebral palsy, we can see this natural history of this progressive hip displacement. So the first x-ray on the left is the child at age 2, and we see that it's very much looking very nicely covered. Kids are often born with a normal hip joint, and we see this kind of progressive displacement over time. So by the time the child's 4 years old, about 30 or 40% of the hip is uncovered. And by the time they're 7, really most of the femoral head is out from under the cover of the acetabulum. You can see as well changes to the acetabulum during this time period, all the way to the final x-ray when the child's 11 years old, where the femur has migrated and really the lesser trochanter is now articulating within the acetabulum. And this, again, kind of shows this progression over a period of a few years, the timing of which can vary from child to child. So it can happen rather quickly, or we can see it take some time. We know that hip displacement is a common problem in children with cerebral palsy. So if we look at a population of kids with CP, we know that 1 in 3 kids will have hip displacement, and that's been shown in multiple population-based studies. More importantly, we know that a child's risk for displacement is directly related to their level of motor function as classified by the Gross Motor Function Classification System, or GMFCS. Hopefully most people are familiar with the GMFCS, but just as a reminder, for kids, there's 5 levels that we use. Kids at GMFCS level 1 are able to walk and run, but have problems with balance and coordination. And we see here in this graph that shows data out of Australia that they have virtually no increased risk of hip displacement. Kids at level 5 need help for all of their mobility, and up to 90% of those kids have hip displacement, which in this study was defined as a migration percentage of 30%. So at least 30% of that femoral head's out from under the coverage of the acetabulum. And this is one study, but again, this has been replicated multiple times in other population-based studies. We also know, if we go back to that kind of progression through the natural history, that as the hip displaces, and particularly once the migration percentage is more than 50%, children are likely to start to develop pain. They can lose mobility. And so for kids that are ambulatory, that can mean loss of ambulation. But for kids that use wheeled mobility, that can also mean loss of mobility in that they cannot tolerate sitting comfortably in their wheelchair. We know that together those things can result in a decreased quality of life for kids. And then as we go through, again, through this kind of progression, the type of intervention that we can offer also changes. So the complexity of surgery can increase. And certainly once we get to that kind of final stage of displacement, the options for reconstruction are lost, and surgeons start having to talk to families about salvage procedures for pain, so where the femoral head is removed. And that's really what we're trying to avoid for these children. We know that we have good solutions for treatment from an orthopedic surgery perspective. This is a study that was done out of Boston looking at health-related quality of life in children prior to hip surgery and after. And they showed that the lower migration percentage, as seen following the surgical intervention, resulted in an increased quality of life score. So we know we have interventions that can be helpful, but it's really about timing of those interventions, and children having the opportunity to get the intervention that works best for that child and family at the right time. And the way to do that is through hip surveillance. Otherwise, this process often happens without kind of signs and symptoms. Kids can continue quite far along in the process without having any pain. And so really the important piece is to go and actively look for the problem. And that's where hip surveillance comes in. So hip surveillance is really the active process of screening to identify and monitor hip displacement with the intent of ensuring that children are seen by a pediatric orthopedic surgeon at the appropriate time. We know there's evidence for hip surveillance in that it's been shown to successfully identify children with hip displacement and ensure those children are seen for orthopedic review. Together with orthopedic care, it can prevent hip dislocations. And I think that's an important distinction to make, is that hip surveillance alone does not solve the problem of hip displacement. It really requires orthopedic management. And there's evidence to show that with surveillance at skeletal maturity, children have better, or youth have better hip morphology. I'm not going to go through all of the studies that support those claims, but it's hard to do a talk about hip surveillance without referencing the work done in Sweden. Their population-based prevention program, CPUP, is 30 years old now. This is a publication that was done in 2014, so more than 10 years ago, of their 20-year data, showing that they have been able to decrease the rate of hip dislocations from 8% to almost nil. And so their conclusion from this 20-year review was that population-based hip surveillance programs enables early identification and treatment. This systematic review was published just last year, looking again at European hip surveillance programs. So the CPUP program has been replicated in Scotland and Norway and Finland. And so this review, again, really just summarized the same findings as per that last article, that hip surveillance can effectively identify and ensure that dislocations do not occur with orthopedic management. The group in Australia is also widely known for their work in this area, and I really like to kind of highlight this study looking at hip health at skeletal maturity. They looked at a group of youth and young adults at a mean age of 18 years. It should not be 18.8 months, but 18.8 years. And they found that limited hip surveillance and access to surgery rather than GMFCS was associated with poor hip morphology. So it's not just kids at GMFCS level 5 if they don't get access. It's really having that opportunity to have surveillance and to have access to care, which can result in better outcomes. They also reported that pain severity and frequency increased with worsening hip morphology, which is not surprising. So we know that there's evidence for surveillance, but what does that actually look like? Well, there's multiple guidelines out there that are available. I've referenced already the CPUP guidelines, Australian guidelines. The Pediatric Orthopedic Surgeons of North America have released hip screening guidelines. The American Academy of Cerebral Palsy and Developmental Medicine have guidelines. A couple of years ago, we collaborated with colleagues in India. They produced national surveillance guidelines. Here in British Columbia, these are the guidelines that we use. And so there is a number of different options. And so what I would encourage people to do if you're not currently following a set of guidelines, there's different options. And I would encourage you to look to see what fits within your system of care. If you look closely at our guidelines in British Columbia, they very much mirror the American Academy guidelines, but we did make small changes based on the system of care here in British Columbia. in that we changed some things from age 6 to age 5 because that worked better with our age at school entry. So as I say, just there's lots of options. And I'm going to say it. I don't think it matters which one people pick. I think there's so many similarities. And this includes across both the clinical exams and radiographs. And I'm going to share just a little bit about how they are similar and how they're different. You'll notice that all include both a clinical exam and an X-ray, and all start early. So by the age of 2, surveillance is recommended. And again, that's kind of across the board in any of those guidelines. In all of them, the frequency for surveillance is based on risk as defined by the GMFCS levels. There's some variability in the frequency of imaging. So for kids at GMFCS level 1, those kids that can walk and run, but just problems with balance and coordination, most guidelines actually don't recommend imaging. There are a few that do. So the POSNA guidelines, the Indian guidelines do recommend imaging. And I think a lot of that has to do with some challenge in being able to sometimes differentiate between GMFCS level 1 and 2, particularly at a younger age. So some guidelines have just chosen to kind of keep those kids together. For kids at level 2, there typically tends to be recommendations for surveillance around age 2 with 6. Some stretch to 10, and some end a little bit earlier. So I think this is maybe one group where there's a bit more disparity. And then for kids at GMFCS level 3, most are annual. And for kids at levels 4 and 5, most are kind of 6 monthly to annually. So there's not huge differences between any of the guidelines. There is some variability, though, when it comes to the clinical exam. Some of the guidelines recommend kind of quite a comprehensive lower extremity exam versus some being very specific to the hip. There's variability in kids, as I've already talked about, at GMFCS level 1 and 2, but also with respect to a group 4 hemiplegic gait pattern. And Jason's going to talk a bit more about some of the evidence around that. So stay tuned for that. There's also some variability around when to stop surveillance and how to whether or not to continue beyond skeletal maturity and the frequency of imaging. And again, Jason's going to touch a little bit on that. And then scoliosis and pelvic obliquity and how those are referenced in some of the guidelines can differ. And I'll touch on that in a later talk as well. So there's lots of guidelines out there. And this was a study that was done a few years ago of the POSNA membership. And 93% of them, they had a good response of 350 respondents. 93% agreed that hip dislocations should be prevented by surveillance. And yet, despite that, less than 20% were actually using surveillance guidelines. And I think this really speaks to the problem of implementation. I think it's easy to have these guidelines, but when we actually go to put them into practice, it can be a pretty heavy lift. And so I'm going to talk a little bit about implementation and some of the lessons that we've learned in British Columbia. I want to start by just saying that there's no one right way to do hip surveillance and to implement it in practice. I'm going to speak to some of the things that we've learned again here in British Columbia, where we have a provincial program, but what works in the province here and how Jason does surveillance in his province and how it would be done in other provinces in Canada. Each of us has a different system of care. And so to say what's going to work for me, it's going to work for Jason, it doesn't work. So you need to figure out your system of care. Recognizing as well that a population-based program may not work in your setting as well. It may need to be regionally. And I think, again, of other provinces in Canada where I could see regionally working better than kind of provincially. And then when I think of colleagues in the United States and having had conversations with them, even regionally doesn't necessarily work. It needs to kind of be within their hospital or hospital system within their clinic. And barring any of that not working, having an individual clinician do surveillance within their own population, I think is also a great way to start. So I would encourage anybody that's thinking about surveillance to first think about what your existing resources and strengths are and who your key partners are. Because I will say that if I've learned anything, it's that we have resources at our children's hospital, but really without the kind of support and partnerships that we've developed across the health system, we would not have success in implementing surveillance. When we developed our program, we kind of had these 5 key questions that as we were developing a plan, thought we needed answers to in order to be able to figure out how to do surveillance. And I think they continue to hold true more than 10 years later when I talk about how to figure out how to do surveillance. And so that's who's going to identify the child, how do you complete the clinical exam, who's going to order the imaging and how do you get that done, who's going to measure migration percentage, always a big one, and then how do you coordinate it and make sure that that kind of cycle of how often it needs to happen is who's going to make sure that happens. And I think if you go and look at the AACPDM hip surveillance care pathway, that kind of walks you through kind of the steps that are recommended for surveillance. Those key questions really line up to the kind of arrows within this pathway. So identifying the child, completing the clinical exam, getting the radiograph, measuring the radiograph, and then making sure that kind of loop continues. So I'm going to try to speak to some of those key points along the way as we go. So first, who will identify the child? And I would say in any of the conversations that I've had across different health systems that it's likely going to be more than one discipline, more than one a group of people. We made the mistake, I would say, in British Columbia when we designed our program. Physiotherapists in the communities across British Columbia identified themselves as being those who would be best at identifying kids and enrolling in the program. And they did a great job at that, but the families then went to their pediatricians and started talking about hip surveillance, and the pediatricians really didn't know anything about it. And so they're like, you don't need to do that. So we learned very early on that we needed to make sure that all members of the healthcare team and families had information about surveillance. And so really looking, again, of thinking about who those kind of key providers are, key team members. If you think of the care of a child with cerebral palsy, it's very much multidisciplinary. So just thinking about who needs to know about the program, who can help make sure that surveillance occurs. And so I would really say that knowledge is key, making sure that you have methods of kind of touch points for different team members. And we spent a lot of time developing knowledge translation materials for different groups, for families, for physicians, for therapists. And if anybody has interest, those are all kind of freely available on our website too. So my email will be at the end of the presentation. So if you have any interest in any of those resources, then please do reach out. When it comes to identifying the child for surveillance, we also learned that diagnosis of cerebral palsy is a possible barrier to enrollment. All of our booklets and pamphlets and information talk about children with cerebral palsy, and despite our best efforts, it can certainly be a barrier when we, again, had therapists going to talk to families about surveillance, and it put them in a challenging position when the child didn't yet have a diagnosis of cerebral palsy. We went into the launch of our program knowing that it might be a problem. And so we didn't require children to have a diagnosis. So when kids are enrolled, they can have cerebral palsy, they can have possible CP, not yet diagnosed, or they can have another condition. And a few years ago, we looked at how children were being enrolled. And I suppose not surprising is that because we knew that we suspected this was going to be a problem, but a quarter of the kids we were enrolling had an other diagnosis. So that could have been things like even as simple as they had a diagnosis of hemiplegia, or they had a diagnosis of PVL, or they had a genetic condition, and nobody had kind of connected the dots there for them that the child had cerebral palsy. So when we actually looked, did those kids actually have CP? Almost 90% definitely did. We had a small percentage that did not. But this really led to an opportunity, I would say, for conversations with pediatrician colleagues around the need for early diagnosis of cerebral palsy. So kind of moving down that pathway, the next kind of touch point would be that clinical exam and who's going to complete it. I mentioned earlier that there's high variability kind of in what's included in the clinical exam. I would say at the very minimum, if you do nothing else, and I tell this to the therapists in our province, is give me the child's GMFCS level. I can at least determine their level of risk if I have that piece of data. So we know there's not great evidence for the physical exam findings. So really, bare minimum is doing this GMFCS. There's lots of resources on the Can Child website for clinicians and as well for families. So if people have a hard time finding the time to look at the classifications, we also spend time with families and have them classify their child. So there's resources on that Can Child website for the family report questionnaire, so families can classify their own child. And so that can be a nice way of getting the family involved as well. Next is the need for a radiograph. And so we want this radiograph to be done in standardized positioning in order to allow us to do the migration percentage measurement. And so that can be a challenge. And I think it's important to recognize that not every X-ray is going to be done perfectly. Some of these children are quite complex and can be difficult to position. So we do our best. And every time a child gets an X-ray outside of our children's hospital, we send this positioning guide along with the X-ray requisition. A number of children get imaging outside of our institution. And so we send these each and every time a child gets an X-ray in hopes that it helps us get that standardized positioning. As I said, we want it in order to be able to measure migration percentage, which is really the standard now for monitoring hip displacement in children with cerebral palsy. I would say, if you ask me, like, what are the biggest challenges of hip surveillance, I would say one would be diagnosis. Probably second is around measuring migration percentage and getting that done through radiology. When we started our program, knew it would be a challenge, and so we chose not to have radiologists, or at least chose not to rely on radiology to do our reporting. This was a study we did a few years ago looking at radiographs that were measured through our program. You can see here that about 70% were done at our children's hospital, and the other 30% were done at community hospitals throughout the province, and there was for 60 different hospitals. So a challenge for us to try to educate all of those radiologists, so we chose not to. But you can see here, really only 20% of images done at our children's hospital had migration percentage reported, and just 3% within the community. So it's really not standard for radiology to report these. That being said, I think there's strategies that people can use, and I think others have found successful in educating radiology departments. I certainly have heard lots of having standardized reporting forms for radiologists so that you're being very specific in what you're asking for. Our approach has been to designate our team members to measure migration percentage. And for those that don't have access to the tools within the X-ray itself, you can use the HipScreen app, which is a freely available app that allows you to measure migration percentage from the child's X-ray. I also just wanted to highlight here, this was a study that was done in Australia a few years ago as well that literally looked at the experiences of parents of children with cerebral palsy and hip surveillance, and they identified that it can be a challenge to get an X-ray done. And so they also highlighted that they didn't think the healthcare team always recognized how challenging it can be. And so I throw that out just as a reminder that we are asking families to do something that isn't always easy. And so we very rarely ask for repeat imaging if the positioning is not perfect. What we're really looking for is that trend over time. So we take every effort to not do extra imaging. If a child has an X-ray for their spine that shows their hips, if they have standing hips to ankles, if they have an abdominal X-ray, we'll use all of those images in an effort to minimize the burden on kids and families. The goal with surveillance is really to make sure that kids are seen by an orthopedic surgeon at the appropriate time when all interventions are available to them. These are the kind of recommendations for when to see an orthopedic surgeon based on the ACPM guidelines. They're what we use as well. The last point is kind of how do you continue and make sure that surveillance happens at the appropriate time? And I think this can be a big challenge as well. For us, we have built a database that flags for us when kids are due. So we have an alert system. But when we started, it was an Excel spreadsheet. I think other options that I've heard is having children have almost like a passport. So it becomes part of the family's routine of the keeping track of when things are due. Certainly in some medical records, there can be alert systems that are set up. But something to think about is kind of who holds that responsibility of making sure that that surveillance continues. So just to summarize, I would say that there are so many guidelines out there. So pick one, start now. There's no need to wait. Really consider that implementation has to be customized to your healthcare setting. Consider your existing strengths and resources. And I would say look at who your multidisciplinary team and really look at developing a coordinated team effort. I don't think I can stress enough about the importance of educating parents and healthcare team members whenever you possibly can. And I'll just end by sharing this graphic. When I started back in orthopedics at Children's in 2009, we did a review of the percentage of surgeries that we did that were salvage procedures. So those ones where the hip is fully dislocated, there's no reconstructive option. And about a third of the surgeries that our surgeon was doing were those types of procedures. And just with advocacy and doing that knowledge translation, making sure people understood the problem, we reduced that substantially. And with the program implementation, that's continued to decrease. These values, this last bar is from 2021. And I think if we do it again, it'll be even lower. So I encourage you just to get started. Don't wait for things to be perfect. Thank you. I apologize for the sun in my face. I'm trying to move myself, but it's a beautiful sunny day here.
It's pitch black here
Yeah, it's the
in
opposite.
Halifax. Yeah.
I don't know if there's any questions, Joel, if we want to keep going.
I don't see any at the moment.
I could ask one question, Stacey, if you don't mind, just as it came up, looking at barriers and things like that. We have a lot of long distances in North America and maybe a little easier to get around in Europe, but certainly in Canada, in our we have hip surveillance program as well in Nova Scotia, and but people are coming from sometimes 8 hours away from another province to come to our children's hospital, for example. So that's not a great option for them to get their regular hip surveillance. How have you tackled that in British Columbia? How do you overcome that barrier?
Yeah, we have 1 million square kilometers, I think we've looked, and And our children's hospital is right in the kind of bottom corner of our province. And so we don't require kids to come to the hospital. We're fortunate. Oh my goodness, the sun is funny. We're fortunate in that we are able to see imaging from across the province within our PACS system. So as long as the child gets an image done in their kind of local health, provincial health system, then we can see that X-ray. And so we mail X-ray requisitions across the province. Kids just go into their local hospital. That's where I say, you know, we have those positioning guidelines. When they take the requisition, they take the position guideline with them. We always look at the X-ray. I think that's the challenge in having things done remotely if you can't look at the image, because that's one thing that I worry about is who's reviewing the X-ray when we've reviewed radiology reporting. It's not great. So the ability to have kids have the imaging at home, but us review it remotely, I think solves that challenge for us.
Great. All right. So maybe I'll go on to our next talk, which is getting to some of the controversies that you had mentioned, Stacey. And first, I was going to talk about hip surveillance or hip displacement and hemiplegia. So let's see if I can share this. Okay, it looks like everything's okay there.
Looks good, but looks like it's not in presentation mode, what we're seeing.
Oh, interesting.
You might need to do the swap.
I'm going to stop sharing. I'll try it again.
Looks good.
Good now? Okay. I did the same thing. I'm not sure what happened, but I'm happy for it. So as Stacey had mentioned, you know, I'm actually in Canada. I'm at the IWK Health Centre, Women and Children's Hospital in Halifax, Nova Scotia, and I've been away for a long time, so it's nice to be back in Canada and particularly back in the Maritimes, where my family's from, and where I've got lots of you know, great friends and history here. But missing my friends at Nemours DuPont, and I'll talk a little bit about some of my work there with the team there over the last number of years. And one of them includes spastic hemiplegia. So hopefully we'll talk a little bit about that today and you get something out of it. I've got a few disclosures here, as you can see. Nothing too relevant to this talk. I was lucky enough to be involved with this study, and this graph keeps being thrown around. And when we first were crunching the numbers on the hip displacement incidence in the Victorian CP register in Australia, we were really surprised to see this linear increase in hip incidence by GMFCS level. GMFCS at the time was also fairly new. So, but this kind of really tuned me in to think that, okay, this classification system is on the money, because there's very few things in medicine we see that sort of come out in this nice linear fashion. So I was lucky to be involved with this very early in my career. But you know, when you look at hemiplegia, we did look at hemiplegia here, and we didn't only stratify by GMFCS, but also by their topographic pattern. If you can see here, hemiplegia in this cohort was you know, you see mostly GMFCS level 1, some level 2s, and a very small level 3s. So all ambulatory kids. If you look at the amount of hip displacement, however, in hemiplegia in this cohort, it was only 1%. If you look carefully at it, you know, Brendan Sue, who's the lead author, and our team suggested that you should, for hemiplegia, then you should do a screening X-ray at age 6. And if it's okay at that point, and looks normal, then you just stop those x-rays and move on, because the likelihood of getting hip displacement is very low, as we showed there. So risk benefits, we thought wasn't a good idea. But this study actually had it was a birth inception cohort and about 11 years follow-up. And as you'll see as we go along, maybe we missed the window at which hips actually do present themselves as a problem in hemiplegia. As you've seen on Stacey's presentation, and as I'll show you here as well, that hip displacement in hemiplegic CP is rare, is more rare than other topographic patterns for sure. But the Winter Gage Hicks type 4 gait pattern has been reported to be at higher risk. And what that pattern is, as you can see here, is basically a kid with hip flexion, a stiff knee gait, and ankle equinus. So that's kind of the more severe end of the Winter Gage Hicks classification. But there's other lesser severity groups as well. Winter Gage Hicks 1 is basically just a drop foot, and everything else is pretty normal. Winter Gage Hicks 2 is a equinus contracture in the hip and knee of normal range of motion. 3 is the same as 2 with equinus, but also has a stiff knee gait and some knee flexion. So, there are those other classifications as well. And we were seeing some issues with those classifications as well, not just Winter Gage Hicks. But so the hip flexion contracture is the thing that delineates the type 4. Joe Rada and Kurt Graham noted that these kids also had internal hip rotation, hip abduction associated, and thought that maybe should be teased out as a separate modifiers for that Winter Gage Hicks type 4. And what they were really alluding to was about the risk of hip displacement in that group. And of course, they also note in their really in their 2001 paper, was really kind of a monograph, really, and commentary rather than data. But they said mostly this displacement happens during the adolescent growth spurt. Here's a case example of a patient of ours where you've got this kid who's got an MP of 41% at age 11, tri-rated cartilage just almost closed there, and then goes on to have progressive displacement with hip pain, and then needing subsequent hip reconstruction. So there's a kid, Winter Gage Hicks 4, GMFCS level 2, left hemiplegia. So, that progression is happening during the peak growth velocity and that growth spurt. So like we mentioned, screening at 6 years old would have missed this. What's the literature like about hip displacement and hemiplegia? Australia has done a lot on this, along with Sweden. They've been some of the leaders in registers for CP in the world. There was this group, Winter et al., had pooled data from 4 CP registers in Australia, almost 1,000 patients. And in that, they found 42 patients with Winter Gage Hicks 4 gait pattern, and they found that 14% had hip displacement. So they found that, okay, they do have hip displacement. They didn't report the other types, however, and didn't mention them at all, which, is fine. But as you'll see, that maybe it was a little bit of oversight as well. That's good. And they said children with hemiplegia don't develop hip displacement at younger ages, which I think we would all agree with. The Norwegians also have registries. Scandinavia is very good at this. And in the Norwegian registry of 335 patients, they had 127 patients with hemiplegia, didn't break them down by Winter Gage Hicks, found only 3% with hip displacement and none with dislocation. But this cohort was very young, 6 months to 7 years old, and they only had 2 years follow-up. So if you take into account that the hip displacement typically happens during that adolescent growth spurt, then this might not have a long enough follow-up to really capture those patients. Let's look a little bit of surveillance guidelines with respect to hemiplegia. Here's the AACPDM guidelines. And you can see when they're looking at all the GMFCS levels, and of course they have their recommendations, but they specifically do a highlight Winter Gage Hicks type 4 only, and have protocols for that based on that. And they say if a child has hemiplegia and type 4 gait pattern, they are at higher risk, and they should be followed with stricter surveillance schedules as are used for GMFCS number 3, but only until age 10, which again seems kind of young. BC children, we just saw those also looking at a group 4 hemiplegic gait, as Stacey said, a lot of similarities between the surveillance guidelines. Australian, same, winter gauge Hicks 4, and really didn't talk about hemiplegia as a whole. But, although I had always sort of looked at this patient group and, with a high rate of suspicion, particularly during this adolescent growth spurt, whenever I saw any change in their gait pattern during that, I'd be like getting a hip x-ray before your head could turn, But anecdotally, when you see big numbers of patients, my practice is only kids with CP and neuromuscular conditions. So I see lots and lots of these patients. And oftentimes the rules that you have get broken. When they get broken more than a few times, you start to say, well, maybe it's not really a rule at all. Maybe it's just a sampling error. So anecdotally, we were seeing hip displacement in other winter Hicks type, and so we thought we should look at that. So this is when I was at Nemours DuPont. We recently published this data, but our goal was really to analyze the risk rates of hip displacement according to the winter gauge Hicks classification, all types, and we wanted to see at what risk factors might inform, we could identify that might inform surveillance protocols. Maybe something needed to change. This is a picture here of Freeman Miller here on the left, Wade Schrader, my partner in the middle, and myself. And, it was Freeman's group here, his 30-plus year experience building the CP department at DuPont, which really we were able to examine. And with the long history of gait analysis there, we were able to classify the winter gauge Hicks, not just by visual gait, but be very systematic about it, determined by instrumented gait analysis and kinematics. And we defined the, quote, unsuccessful hip. One of my research fellows suggested that name. We thought, okay, it kind of stuck. So the unsuccessful hip is migration percentage greater than equal to 30%. Most of the surveillance guidelines would say 30% or 33%, or the need for hip reconstruction for hip dysplasia, not for derotation for gait. And we, in the end, we had 144 patients which were included. And out of those, we had about a 12% rate of hip displacement or unsuccessful hip. But when you look at the winter gauge Hicks types, you see that winter gauge Hicks type 4 certainly had a high risk of hip displacement, 24%. But look at the other ones. Even type 1, which is just a drop foot, had a 10% risk. And, type 2, which is an ankle equinus, almost 10%. And type 3 had about 7%. So, these are not inconsequential numbers. Certainly you shouldn't just ignore that. So we wanted to look a little further and say, well, maybe it's not just about the sagittal gait pattern in type 4, which is the issue. Let's look a little deeper. So we did that. We looked at kinematic and kinetic variables in univariate analysis and found that, if you look at hip flexion, that was a risk factor. These were all by gait analysis, by the way. Internal hip rotation, that was outside of a standard, normal standard deviation, and hip abduction. So those were our univariate risk factors for unsuccessful hip. And when we did a multivariate analysis, really the hip flexion, which is part of the winter gauge Hicks 4, the only part of it was actually came out of the mix. And it really boiled down to internal hip rotation and hip adduction during gait, either or and. Having one of those was associated with risk factor, irrespective of their winter gauge Hicks classification. Now, of course, this wasn't population-based like the Melbourne or, the Scandinavian registers or BC, but it did have 144 patients, which was the largest to date. And, the DuPont group and institute is kind of like a population in itself. The patients typically stay there and stay there and don't tend to move around too much. So what did we learn? Hip displacement and hemiplegia. Well, I learned that although it's uncommon, it's not super rare. It's still about 12% overall. And winter gauge hip type 4, certainly it was higher risk, but it wasn't in of itself predictive. It was actually related to axial plane rotation and during gait, internal hip rotation, and also coronal plane adduction. They were the risk factors regardless of the winter gait tick classification. And, we felt that this should directly impact hip surveillance for patients with hemiplegic CP. And I actually said to Stacey as we were going through this before the webinar, I said, I'm not going to put in what I think should happen with respect to the hip surveillance, but I decided I would say it because I figured someone might ask. And also it's in our paper. So if you want to look at this open access paper, it's out there now, just published last month. But from all this, the reviewers really pushed us to give some guidance. And so this is what we said. We said for those patients with hemiplegia, regular hip surveillance should, all types, winter gait tick types, should be considered, particularly for those with internal hip rotation and or hip reduction during gait. Those are our risk factors. This surveillance should commence at age 7 years. So remember, the Sue recommendation was if you have a good x-ray at 6, forget it. We're saying you should start at 7 and then annually until skeletal maturity, which we defined by tri-rated cartilage closure. And consistent with the findings of Lindgren, which is one of our previous papers on this, if the MP is more than 28% at tri-rated cartilage closure, then you should continue doing biannual x-rays until age 18. So that's the best we could come out of what our data and out of our the best data that we had based on our large cohort. And, I think it needs to be looked at in other centers as well to see if this makes any, if this holds water in other jurisdictions as well as ours. But we hope it'll be helpful and maybe might inform the next iteration of these surveillance programs. Maybe some of this will be taken into account. Thanks very much. This is my hometown of St. John's, Newfoundland, from Signal Hill. We just had the Canadian Orthopedic Association there. It's a great place. If you ever get a chance to visit, wonderful. And if you want to get that paper, here's a little QR code you can scan for that to get it. Thanks very much. Okay, I think I'm back.
Jason, I can ask you a question.
Okay.
Thanks for doing that work because we are right now doing a review of all the literature for updating the ACPM guidelines for surveillance. And I think the group 4 gait will be an area where we can do some work. And I found it interesting in looking at the literature that despite it being in guidelines for well over 10 years, that there's really no literature out there to support it one way or the other. And so we've recently looked at some data at our population, and even the ability for us to consistently classify kids with a group 4 gait clinically was proved to be very challenging. So in some clinical exams, it was there and some not. And it didn't matter whether kids were seen kind of at our institution or kind of in the community. So I think this will be an important paper for informing guidelines. I'm curious if you looked at what happened at the pelvis with respect to pelvic obliquity at all in that population.
Yeah, sure. Well, number one, thanks for that. We were definitely hope that some of this data would be useful. And it's funny when we submitted this paper for publication, and I will answer your question, but we submitted it, we had some of the reviewers come back and say, you said this is expert consensus and there's no data or very small series data. That's not true. It's based on very rock solid evidence. And I'm like, actually, if you look at it, there's not. There's really nothing there. So I also thought it was on rock solid footing because when things get said over and over and over, it's you tend to believe that it must have come from somewhere, but it definitely comes from good experience. I mean, it's true that the winter gait ticks type 4 is the highest risk of that, but it's not the only one. And so, and it's probably not related to the sagittal gait pattern at all. it's probably just related to the position of the hip. Anna Prezito did a paper looking at this a couple of years ago, and really they said that the position of the hip is important and where the acetabular dysplasia happens. And I think that these transverse and coronal plane rotations or positions are causative there. Pelvic obliquity is also, you could think of that as another positioning of the hip, right? So the hip proximal femur develops based on its joint reaction force and forces on the hips, things like that over time. But the acetabular dysplasia probably lends itself to the instability. So wherever that hip's pushing, the acetabulum gets deformed there. So I would have liked to have looked at pelvic obliquity, and we considered it. But the problem is that we do our hip surveillance x-rays in the supine position, and they're told to level the pelvis and put the patella forward. So unless you've got a big scoliosis up on the top, it's really tough to know if you have true pelvic obliquity. And is it suprapelvic, infrapelvic? So you really need erect x-rays to do that. We did use erect x-rays in our other paper where we looked at ambulatory CP. And we did find a factor. So I expect it would be in this as well, but we didn't feel it was right to include it because we really couldn't say for sure what was pelvic obliquity and what wasn't based on supine x-rays. Does that make sense?
Yeah, thank you.
All right. Sorry, I'm a long-winded. I talk too much. I know that.
So thank you both. There is a question in the Q&A, and it's from Jonathan Lau. I'll read it. There's a little bit here, but so that everybody else can hear it as well. So he says, great talks, both of you. I was wondering, with this new information, it sounds like the natural history is that these hips are going to be at increased risk of dysplasia and uncoverage, but I guess how will that guide your treatment? Would earlier treatment of addressing adduction contractures, hip flexion contractures, and potentially even derotating a femur while not addressing the acetabulum? Or would you wait until you actually get dysplasia to address these issues and or address the knee and foot and ankle with SEMLS when you are forced to? Did you catch all that?
Yeah.
Oh,
Hi, Jonathan. Thanks for your question.
And do you see that? Are you reading it there? There's a
Oh,
little
yeah. In
addition.
terms of pelvic obliquity, yeah.
Yes. So I'll read it for the benefit of others. Yeah. In terms of pelvic obliquity, I was wondering with the hemiplegia, with the mild FFD of the knee and the shorter limb, whether that was more protective in your WH3s, which almost seem to trend with less unsuccessful hips.
You got a lot in there, Jonathan. Thanks for those questions. I guess I'll take it because it's kind of surgical. What I would say is that the first thing you need to do, like Stacey said, is you need to detect. You need to identify. So if you don't identify, you don't know. And then, what often happens in kids with hemiplegia, I'm often doing big surgeries on them when they're like 13 or 14 years old. They've already got pain. So they already got some established arthritis because they, even though I think, at DuPont and now me as well in Halifax, we're x-raying them more probably than the surveillance programs guidelines would suggest. But that wasn't always the case. And I would say most of the kids I've done surgery on have been more late. So I would say that, yes, treating early is better. These kids don't have their hips coming out of the joint when they're 6, 7, or 8, though, like bilateral CP, GMF says 4 or 5. They are later, and it is tied to the adolescent growth spurt, and probably tied to some abductor function too. We found abnormal abductor moments too was also quite prevalent, so it may be related to that. So, anyways, I would say detect. If you're looking at somebody with hemiplegia and they get their knee turned in and their hips adducted, regardless of what their winter gauge Hicks height is, just do an X-ray and look at them. Your other question was in terms of pelvic obliquity. You're saying about mild fixed flexion deformity and limb length discrepancy. Yeah, there may be some relation to positioning there. So, in the same way that an internally rotated and adducted hip positions the femoral head in an abnormal position, which has lateral pressure on the acetabulum, just as we were talking about earlier, that kind of sort of long leg type dysplasia or whatever, pelvic obliquity from that may also do similar type things. You're probably right about that. I don't know the answer.
And one other new question, thank you, came up from Giovanni Oliasantalan. I'm sure I'm mispronouncing that, but does current hip surveillance in cerebral palsy risk overtreatment, undertreatment, or inequitable access to timely care?
That seems like a Stacey question.
I don't know. I just get them to the surgeon at the appropriate time, right? You know what? I think it's a good question. I think the way that I look at it is we get families to the surgeon at a point where they can have those conversations and have the option to treat. I don't think because we're getting kids to the surgeon means that they need to necessarily treat. I think we see families that want to wait and see how things progress. So I think it's certainly there is that option. I think it comes down to maybe the philosophy of the surgeon maybe a little bit in how to treat, but I think more to come on kind of the intervention piece, hopefully from the work that Dr. Narayanan's doing with the multi-center kind of outcome study for treatment. The inequity, I hope that we actually limit actually the inequity, and that in doing population-based surveillance, we're providing every child the opportunity to have surveillance. And I think in our population where it is spread out across many rural and remote areas, that those kids would not typically, if they had to come to Children's Hospital annually or whatnot, get access to this care. So I think hopefully we're increasing access rather than limiting it.
I would agree. I've got a little bit about that. If we, hopefully we get to the last talk. I've got a little bit about that in as far as the balancing risks and benefits with respect to hip surveillance. So we could talk about that too later. All right. Maybe in the interest of time, we should move to the next talk. Is that right? I think that's me again.
Yes, that's right.
Yeah. Okay. And hopefully I can make this work. Okay. How's that one? Did I do it? All good?
Yes.
You see that? Okay, perfect. Thanks. So I wanted to talk about another controversy. This is another question that I had, and I had so many fellows and residents and everyone else that worked with me ask this question, and I really didn't have an answer for them for a long, long time. I feel like I have a little more of an answer now about hip displacement after skeletal maturity. So, do we still need surveillance, or as Stacey said in her presentation, when do we stop? Do we just stop when they're 10, like some of the guidelines say, or do we stop when their triradiate cartilage is closed as a proxy of skeletal maturity? Do we stop at 18? If you look in the literature, it's not really, it definitely wasn't clear, but I'll try and go through that and see if we can make it a little more clearer. You've seen this, guidance for frequency of x-rays in the skeletally mature, pretty well established. You saw all those guidelines. And but after skeletal maturity, it really gets a bit nebulous. And that's when the expert opinion comes in again. I'm going to get in trouble with somebody who's going to say there's lots of evidence. Well, there's not. Go look for it. But here's one. Here's a kid, for example, 16-year-old, who at age 13, you can see there on the left, had about a migration percentage of about 30%, I would say. A little bit of a subluxation. But this would have been a patient that I probably would have stopped, would have not x-rayed again. But look what happened to him. At age 16, he progressed, despite being skeletally mature, to NP greater than 60%. He's got this horrible seagull-shaped acetabulum, and then ended up requiring pretty significant hip reconstruction surgery at an older age, at age 17. I think the good result was done there. But, ideally, you'd want to get this a lot earlier. If you look at the literature and the guidelines, so, I was trained in Australia with Kurt Graham's group at Royal Children's, so this was really drilled into my head. But the revised Australian hip surveillance guidelines in 2015, and they've since done it again in 2020, from national working groups based on, after skeletal maturity, it was really based on a systematic review and expert opinion. And they suggested continued surveillance after skeletal maturity with additional risk factors for GMFCS level 4s and 5s. And those risk factors were kind of the same as what the ACPDM had said: an abnormal MP, migration percentage greater than 33%, progressive scoliosis, and pelvic obliquity. And pelvic obliquity keeps coming up. That does seem to be a significant risk factor in general. And BC is very similar to that, and the CPUP program, Sweden, they say if it's less than 33% until facial closure, then you should be able to stop. In BC, it says if it's less than 30% and no clinical concern, you can stop. And what we found out, I don't think they're wrong, but we just didn't have good data to back those guidelines up. So because these guidelines were based on low-level evidence, expert opinion, consensus, and case series with low numbers, we thought we needed larger studies to confirm the risk factors, inform the frequency of x-rays, how often do we need to x-ray them, and revise or substantiate current recommendations. And this is Dr. Miller again. He comes up a lot because he along with just a few contemporaries, really started this looking at hips in a systematic way and understanding they were a problem and treating them when a lot of other people were treating these kids nihilistically and based on the fact they couldn't walk, so it mustn't be a problem. We know that's not the case. You see a hip right here, severely destroyed, with severe hip dysplasia and a lot of pain, and we don't have a lot of good surgical options for that. So Miller and Bagg, this was the evidence used in the only evidence used in the hip surveillance and from Australia. We had an MP greater than 30%, and at ages 8 to 18 years, they were at risk of further progression after skeletal maturity. And Dr. Miller had suggested that it's important to continue monitoring those subluxated hips into adulthood. So if it's, again, more than an MP of 30% or whatnot at skeletal maturity, then you probably should keep watching them until age 18. But this was pre-GMFCS. The follow-up wasn't super long, and the radiographic surveillance wasn't, all that frequent either. So we, revisited things at Nemours DuPont again, and looked at the database, which was now 20 years larger. Again, Dr. Miller's still in the mix and mentoring his young compatriots on this, and he had very liberal hip surveillance in these older children and young adults, not only with hemiplegias we talked about, but also skeletally mature patients. So it gave us an opportunity to really have data where other programs would have said, we're not x-raying them because it doesn't fit the guidelines. So sometimes it's good that you have a rule breaker in your midst and it gives you an opportunity. So who needs it? When do we stop hip surveillance after skeletal dysplasia? We want to determine prevalence of hip displacement, risk factors after triradiate cartilage closure, which is a proxy for skeletal maturity. And our primary outcome measure, again, was the unsuccessful hip. But in this case, we had an MP greater than or equal to 40%. But because we felt that this was a more conservative measure, which if you get that, you're basically going to operate on it. We know that hip's not going to do well. And so our results, we had 163 patients and found that 22% of them went on to an unsuccessful hip after skeletal maturity. And when we looked at risk factors, we found that by multivariate analysis, it really was pelvic obliquity and the first MP at triradiate cartilage closure, which were the main risk factors. So basically, if you have a high MP at triradiate cartilage closure and pelvic obliquity. Those were your main risk factors that, hey, there's a chance this hip is going to keep coming out of the joint. You better do some surveillance on it. But we wanted to know, and also being a male doesn't help either, In general, I would agree with that for myself. Sorry, that was a joke. So if you look, though, we wanted to know, what is the MP, that high MP that's a problem? So we just said the first MP after triradial cartilage closure is a risk factor. We did a ROC analysis on that to see, okay, what is the threshold? And we found it to be 35%. So if you have an MP of 35% to triradial cartilage closure, you better watch that one, because there's a significant chance that it's going to progress. And that was something that I really didn't know before. So now when the fellows ask me that, I quote that number to them. Survivorship for males was a lot worse than for females, and that may be related to maturation, bone maturation, and other things. And certainly there's a later age of triradial cartilage closure in males versus females. So males are just continuing to grow for longer. If you had hip surgery prior to triradial cartilage closure, this was protective. So, and maybe that gets back to Giovanni's question about, or maybe it was Jonathan's question about surgery as a preventative measure. Certainly we found that for these kids, if you had a surgery that was after age 6 years, but before skeletal maturity, your survivorship of hip displacement after skeletal maturity was much higher. I think that makes sense. So what did we learn about hip displacement after skeletal maturity for GMFCS level 4s and 5s? Well, I learned that despite them being skeletally mature and their growth slowing way down, that doesn't mean that we don't have to worry about those hips coming out of the joint. 22% of them still did. And so that's still relatively high. Overall in CP, the risk of hip displacement is 35%. So 22%, that's 2/3 of that, right? Thereabouts. So we suggest annual hip surveillance x-rays after triradial cartilage closure if you have these risk factors: an MP greater than or equal to 35% before or at triradial cartilage closure, significant pelvic obliquity, and if you're male. I would say I wouldn't do it just if you're male, but certainly if you have that combination, and with the MP being the most important one, then you should be really looking at those. And if you do if you catch these things early, then if you do bony reconstructive surgery at the right time, then your survivorship and the risk of progression after skeletal maturity is a lot less. But please perform it after age 6 so you don't have to do it again because of high revision rates after that. So what about ambulatory CP? So that was GMFCS level 4s and 5s. The ambulatory CP, we said, okay, well, now we know that. Now the fellows are asking about, kids with diplegia. And so here's a kid, GMFCS level 2. This is actually Winter-Gage Hicks type 4, and that's the same person. No, it's a different person. No, it's the same person I showed you before. So, ambulatory and getting to problems. So again, if you look at ambulatory CP, going back to the Australian hip surveillance guidelines as the sort of proxy for the rest of them, they looked at systematic review and pooled data and found that you should do additional surveillance of adolescents after skeletal maturity who are ambulatory with additional risk factors. So actually, it would be those with a leg length discrepancy or gait abnormality, progressive scoliosis, or pelvic obliquity. But again, these are based on, again, small numbers, expert opinion for GMFCS level 1 and 2 especially. So we did a little reprise of our study and kind of flipped it around to look at ambulatory CP, GMFCS level 1 to 3. Our primary outcome measure now was a little less conservative because or a little more conservative, I guess, because having an ambulatory child with an MP of greater than or equal to 30%, we know from other studies is not good for hip health. So we picked an MP greater than or equal to 30%, or a migration progression of greater than or equal to 10%, or having reconstructive surgery for hip displacement. So that's our unsuccessful hip in this case. We looked at a lot of other risk factors and comorbidities. We had less patients here, as you can imagine, meeting the criteria of having hip surveillance x-rays in these ambulatory kids, not as apt to do them as regularly. but we got 76 patients in our cohort, and final follow-up about 5 years after trivedic cartilage closure, and we did follow them before that as well. You can see the breakdown of GMFCS level 1, which was the lowest number, and then 2s and 3s were about 40% by that already. And we had a lot of them had comorbidities and hip surgery prior to trivedic cartilage closure, and we took that into account as well. But out of that 76, we had 16 patients, or 21%, that had an unsuccessful hip. So remember, for the non-ambulatory, it was 22%. And if you look at the MP for successful versus unsuccessful groups, definitely higher in the unsuccessful group, and had some progression from trivedic cartilage closure. We did a chi-square analysis looking at these different factors, thinking that GMFCS would have an impact. It didn't. Topographic pattern, being diplegia, had a higher risk and hemiplegia on the whole, despite our previous conversation. And epilepsy also was a significant risk factor, which we think is kind of a proxy of disease severity and may have to do with issues relating to selective motor control and things like that. Just a proxy of that. So, but interesting, GMFCS didn't have an impact. We did a multivariate analysis on this, and we found that the only thing that really shook out at the end of it was that first MP at trivedic cartilage closure as the risk factor. Everything else, including seizure presence and male gender, which were there on Univator, didn't come out in the multivariate analysis, so they were dependent factors. And then we wondered, well, what's the threshold? I could hear the fellows wanting to ask me before I even got it out of my mouth. And here we found the threshold was less. So if you had more than greater than or equal to 28% migration percentage at trivedic cartilage closure, again, you better have a look at those hips afterwards, because you do have a higher risk of MP progression and need for any interventions. Again, the males had a lower survivorship than females for the reason we already talked about. So for the ambulatory kids, after skeletal maturity, hip displacement, what did we learn? Well, the risk is kind of similar to non-ambulatory CP. And what we're suggesting is annual hip surveillance x-rays after trivedic cartilage closure to continue for those kids when you have an increased MP. And up to about 18 is what we've suggested based on mostly Dr. Miller's data, to be honest. There's really nothing beyond there. Surprisingly, GMFCS level was not associated, and the risk in hemiplegia was very low in this big group. But when you look at hemiplegia within it, as its own entity, we see different things, of course. And most of them were bilateral CP. And if you have an MP less than 20, you should try and go for an MP of less than 28% by skeletal maturity as the goal, whether by surgery or through X-ray surveillance. Thanks very much. And these two papers are available if anybody wants to have a look at them. They're a little confusing because we basically titled them exactly the same and just said ambulatory or non-ambulatory, but you'll find them, I'm sure. Thanks for listening. This is Halifax from George's Island. Just really gives a good look at the city, and it's really a beautiful place if you ever get a chance to visit.
Great, thank you. And Stacey, did you have another? What's next?
I do. Do we have time? It's a short one, so maybe we can do this short one and then.
Okay.
Yeah, sorry, I'm so long.
No, we're good. It's all, you've given the preview for this one anyway. You see those slides?
Yep.
Good, great. So I'm just going to talk a little bit, very briefly, about the hip, spine, and really the pelvis, which Jason's just given a good preview kind of on, I think, what my ultimate theme will be. We know that you've seen this graph multiple times tonight. We know this direct relationship between displacement and GMFCS. But we also see the same relationship with risk for scoliosis. This is data from a study out of Australia looking at risk of scoliosis of a Cobb angle greater than 10 degrees. So quite a small curve, but you see that risk increases with GMFCS level. But if we look at risk for a more clinically significant curve, more than 40 degrees, really kids at GMFCS level 4 and 5 are who is at risk. And similar data is available out of Sweden, looking at, again, percentage of kids with Cobb angle greater than 40 degrees. We can see, which Jason kind of talked about with, progression of displacement beyond closure of the triradiate cartilage and as kids get older, and we see this same kind of continued increased risk as kids go from age 10 to 20 and their risk for a scoliosis. What I am mostly interested in learning more about is this risk with pelvic obliquity. So this is another paper that was published out of Sweden looking at risks or looking at incidence of pelvic obliquity in kids by GMFCS level. And again, across GMFCS levels between levels 2 and 5, there is pelvic obliquity. It increases with GMFCS level. What they noted with pelvic obliquity, different than scoliosis, was that it is identified earlier than what scoliosis onset is. The causes of pelvic obliquity, so from a suprapelvic perspective, is the scoliosis. More common in kids at GMFCS level 5, sometimes in combination with infrapelvic causes, but certainly for kids at GMFCS levels 2 to 4, more often having infrapelvic causes where that could be asymmetry in tone, contractures of the adductors or abductors, hip dislocation, or leg length discrepancy. Those are kind of all common things you'll see in the literature as causes of infrapelvic obliquity. But really what the question is when I think about surveillance and what's the clinical kind of correlation between scoliosis, pelvic obliquity, hip displacement, what's that relationship and what's the consequence for surveillance? And I would say if you look at the literature, particularly dating back a number of years, there's kind of controversy there. There's no kind of clear relationship, but over the past few years, there has been a few larger population-based studies. This was one, again, that's I referenced a couple of slides ago, out of Sweden, looking over a 5-year period, 337 kids, right from infancy up to age 18. They found 79 kids out of that 337 had pelvic obliquity greater than 5 degrees, and of those, 38 had a scoliosis and pelvic obliquity. They found a strong association between the high side of the pelvic obliquity and the side of the scoliosis, as well as the high side of the migration percentage. What was also interesting is looking at where asymmetry in migration percentages was greater than 5%. Pelvic obliquity was seen in 62 kids, and of those, 50, the higher side had the higher MP. So certainly more often, but not always, is that higher MP on the side of the high side of the pelvic obliquity. Another study just looking at non-ambulant children out of Norway found similar results for the high side of the pelvic obliquity, more often having the unilateral displacement. And again, kind of that relationship between hip, pelvis, and scoliosis. Typically, the high side of the pelvic obliquity, the displacement, and the convexity of the scoliosis on the opposite side about 3/4 of the time. I threw this in there because there really is not a lot related to ambulant children with CP. So thanks to Jason and his colleagues for really trying to fill some of this gap. And this is partly why I asked the question earlier about the pelvic obliquity, is that we had this small case series of kids at GMFCS level 2 who we thought had asymmetric diplegia and really didn't fit within the guidelines. And what we were seeing is all of them had a fixed pelvic obliquity and they had kind of rapid displacement over time. Um, and so again, kind of coming back to that question, what does it actually all mean for surveillance? Um, and so I think what I'm hearing more and more is that risk factor of pelvic obliquity. And so really considering how we monitor kids with pelvic obliquity across GM-FCS levels. And so I think it's an area, as I say, that, Jason's trying to fill that gap. And I appreciate that we still have more to learn kind of on what the risk factor is related to pelvic obliquity, displacement, and GM-FCS levels. So that one's a short and sweet one.
Okay, great. Thank you both. Denisha, I'll get you to go ahead and throw up the other slides. I see we have one question that came in, and we have I'll read it out for you. It's another from Giovanni. After adult hip surveillance, while treatment options truly improve adult cerebral palsy hip outcomes, and when is surgery justified over conservative care?
Well, you're not asking the easy questions, Giovanni. I most I see kids up to about age 21 typically, and usually we want to make sure that their hips are well seated, without arthritis, you know, concentrically located, mobile, and pain free. That's our goal. And I think the way to do that is is regular hip surveillance with all the things we talked about tonight with risk factors and those sorts of things. When you get to the adult stage, after age 18 or whatnot, and you have a hip that's been subluxated or dislocated for that amount of time, it's unusual to be able to reconstruct that hip, and you often need to do salvage type procedures. So I would say that the outcomes are not as good for those that are not treated until late, you know, late adolescence, early adulthood, that type of thing. So the goal is really to do earlier surveillance than that and treat them. And then if they've missed the boat and they're coming to you late, then you just have to treat them on a case by case basis and determine, well, are there ways for us to temper their symptoms, and what's the best approach for that. It depends on how what the hip morphology looks like, really. Don't know if that answered your question or not.
So thank you. I don't see any other questions, just some thank yous are starting to come in. And so we'll do the same here. Thank you very much, both. Very informative and insightful perspectives and yeah, just information. So thank you very much. Um, yeah, just lots there. And I look forward to, so this will get posted and folks know how to get in touch and follow up on the information that you shared. So that's wonderful. And yeah, just we'll plug again that you'll both be participating in the symposium coming up in September as panelists on the CP hip topic. And obviously, there's so much more that's going to be there and lots of networking and a opportunity to connect with these folks and so many others. So the registration's open. People can check that out. And there's lots of other ways that people can stay connected with the Hip Hop Network too. So on the next slide, you can see we've got our website. And if you haven't already, you can sign up as a member of the Hip Hop Network. It's free. It's just a matter of staying connected and hearing about when we have other cool events like this. And other updates that happen across the platform. It's a growing thing. So thank you again, Dr. Howard and Stacey Miller, for this wonderful contribution to our webinar series. And I don't know if there's anything else, but otherwise we'll sign off. Did you have anything else to say? Otherwise we'll close out.
Other than thanks a lot for the
Thanks. Yeah.
opportunity. It's a lot of fun, and it's always good to hang out with Stacey.
Yes.
Okay, well,
Thanks so
thanks
much.
again. And thanks everybody who's joined, and look forward to the next one.
All
Bye
right,
for
take
now.
care, everybody. Good night.
All right.